Hi, it's your old respiratory care buddy, Chuck Mulholland, and I've decided to try another one of these podcast thingies for your listening enjoyment. I just recently did a lecture on artificial airways, simple airways like pharyngeal airways, and some basic things about airway management. And it's a pretty big module I lectured on. I think it had over 70 PowerPoint slides, and it took me several days to get through it all. But I think I'd like to break it up into some basic sections, maybe three, and maybe at the beginning, and on this module, just focus on what I call simple airway maneuvers and the use of pharyngeal airways. Then after that, if that goes well, maybe I'll record another lecture about alternative airways such as comba tubes, laryngeal mask airways, and other supraglottic examples. And then lastly, if things go well, I'll finish it with the actual tracheal airways, namely endotracheal tubes and tracheostomy tubes. So I'll kind of use the PowerPoints I did for my lecture and modify it a little bit as we go. Basically, maintaining an airway for our patients is one of, if not the most important role a respiratory therapist can provide. And that can range from the very simplest, most basic maneuvers like making sure the patient's positioned properly. For example, for shorter breath, getting them to set up upright to see if they can tolerate it, assuming they can maintain their own airway and keep it open and patent naturally. Or if they do lose consciousness or we find them not very responsive, maybe putting them in a head tilt chin lift position and opening the airway might be all we have to do. But, I guess this lecture kind of takes things a little bit further. What if you do the ABCs, airway, breathing, circulation, which is what American Heart used to emphasize back when I was a young therapist. I know they've changed it now, and it's CAB, focus on compressions first, then airway and breathing later. But I guess as a respiratory therapist, since our focus is on the airway, really nothing else matters if we cannot open and establish and maintain an open airway for our patient. So again, this part of the lecture is going to focus on the simplest techniques and then getting into invasive techniques, but with the simplest types of airways, namely the pharyngeal airways, and we'll talk about those. But this module later, like I said, when I present this to my students, it starts from basic all the way up to the advanced, like clear up to an emergency bedside tracheostomy. So that'll be for the third section if we do that way. When I did my lecture, one thing that an older textbook we used to use for our class, and we've kind of went away from it and we switched, but I think it's still worth pointing out, airways can be classified. Now, yeah, we're talking, if we do place an airway into a patient, they're all artificial airways. They all are man-made and they're plastic or whatever, made in a factory somewhere. But one of the texts we used to use made a big differentiation between what we would term simple airways versus artificial airways. Simple airways were just classified as airways that are really just meant to get the tongue out of the way, because the tongue is the most common form and cause of airway obstruction. So by simple airways, we're namely talking about pharyngeal airways. The nasal pharyngeal airways are nasal trumpets and oral airways. They are simple in their design. They're just pieces of plastic or rubber meant to get down into the pharynx and get the tongue lifted up off the posterior pharyngeal wall. And that's really it. Artificial airways, on the other hand, again, this is an older way to classify things, are any airways that you can actually hook a manual resuscitation bag or a ventilator directly to and ventilate a patient through those. So that would be tracheostomy tubes, comba tubes, laryngeal mask airways, endotracheal tubes, that kind of thing. So it's maybe a little older way to classify and categorize airways, but I still think it's worth pointing out. Simple airways you don't ventilate through, but they can make ventilation more effective. Artificial airways are those that can be directly connected to some kind of breathing device. So the two specific simple airways I wanted to talk about are the nasal pharyngeal airways. I was told they're called nasal trumpets. I think I'm lecturing from Ohio, so wherever you may be listening, maybe they call them NP tubes, or just they call them nasal pharyngeal airways. But when I was taught, We just call them trumpets, nasal trumpets. And then the other type of simple airway are oral pharyngeal airways. Again, these simple airways are also classified as pharyngeal airways because they both simply go down into the pharynx and they don't go deeper than that, and are really there just to get the tongue out of the way. So really, when I talked about this module, I guess I'll keep it in this section as well. There's really 4 main indications for any of the airways, whether we're talking simple or the more advanced artificial ones that we can ventilate directly through. The first indication would be to relieve airway obstruction. And again, usually the tongue is the most common cause of airway blockage or obstruction. People, namely patients, lose consciousness, they lose muscle tone in their upper airways, and their tongue starts flopping around. And you'll know it when you see it and hear it. They sound like they're snoring, they're not alert, they're not awake. You really question if they're moving much air beyond that obstruction. So you got to get the tongue out of the way. So as far as what airways fit that bill, both simple and artificial airways should do that. They should relieve airway obstruction, namely getting the tongue out of the way. The second indication for any of these airways is to facilitate removal of secretions, aka make suctioning easier. So simple airways can do that. The oral pharyngeal airways, maybe not so much, but I have seen people take 14 French catheters and maybe go down the middle channel of a Goodell oral airway, and we'll talk about those in a few minutes. It's not really meant for you to suction through, but I have seen it done, and it does make it effective because you can reach down deep into the pharynx and remove secretions that way. But the simple airway that really helps make suctioning easier is nasal trumpets. It gives you a nice clear path through the nares and without you damaging nasal mucosa or rupturing or ravaging the turbinates or concha in the nose. And it's less traumatic for the patient. So if you got someone that needs frequent nasal tracheal suctioning, nasal trumpets really make that easier, and we're really going to make it better tolerated for the patient. And the more advanced artificial airways that we can ventilate through definitely make suctioning easier because you're right in the trachea for, at least tracheostomy tubes and endotracheal tubes give you a direct route down there. Third indication, protect lower airways from aspiration. Now, obviously, the pharyngeal airways can't do that because they do not have cuffs. They're just simply there to get the tongue out of the way. They have no cuff to inflate, to seal off your trachea and protect the lower airways from patients aspirating vomit or pharyngeal secretions. So only artificial airways with the cuffs can do a good job of protecting lower airways. And then the last but not least, facilitate application of positive pressure ventilation, which is just a fancy way of, hey, can we ventilate directly through that airway? Only artificial airways can do that. We have no adapters or any pieces or parts on the pharyngeal airways that will allow us to directly ventilate through those devices. Now, they can make ventilation more effective by getting the tongue out off the posterior pharyngeal wall. But again, you can't directly ventilate through them. You can use a bag valve mask with those devices in place, and maybe they make it a little more effective, but you can't have that, universal adapter that allows you to ventilate through artificial airways. We'll talk about those in the, a later section. So a big thing you got to do when we're talking about airways is how do you select and establish an airway with your patients? Well, first you got to recognize when your patient is having a hard time or trouble maintaining their own airway. So you always go back to signs and symptoms of what your patients are showing you. Are they snoring? Do they have a decreased level of consciousness? Are you hearing audible secretions, bubbling and gurgling around in their upper airway? Do you hear stridor, that high-pitched inspiratory kind of squeak-wee sound from the trachea and upper airways, sign of airway obstruction? Definitely concerning. Are they showing you that they are just having an increased work of breathing? Do you see, substernal retractions, intercostal retractions? Do you see asynchronous movement between their abdomen and chest, or paradoxical breathing? Those are all things that are showing you that your patient's struggling, and the reason they're struggling might be because they're not maintaining their own airway enough. You might have someone that's in a comatose state and they're breathing fine. They're not showing you signs of respiratory distress, but because of head trauma or a stroke or something like that, they have a big time loss of a gag reflex. Now, even though they're not showing signs of respiratory distress, you don't just walk away from those patients. If they show you they have no gag reflex and they don't react to you trying to suction them or anything, they need their airway protected. You cannot assume that they will cough like when you're gone and know what to do with those secretions if they cough anything up, or if they vomit, are they even alert enough to manage that and roll to the side and spit it out or anything. So if they're in a comatose state, they're not. So even though they're not showing you signs of respiratory distress yet, the fact that they have such a depressed or absent gag reflex is concerning, and they're going to need an airway for airway protection. So basically, I guess it's like anything in respiratory therapy. Think horse before zebra. So start simple before you get too exotic and go right to the big guns. So again, the first thing you might want to try as a student or a new therapist or anybody out in the clinical setting is check the patient's position. Are they seated or positioned in a way that they can maintain an open airway? Maybe you just need to, especially for infants, you've got the short little fat necks and double chins and they're chubby little babies. Sometimes they just need their head and airway put in more of like a neutral or sniffing position. Maybe you just put a towel roll underneath their shoulder blades to kind of get their shoulders elevated. And it's not such a violent, not that it's violent, but it's not such an exaggerated head tilt chin lift like you do with adults. And babies don't need that, especially newborns and preemies. I'll never forget, we extubated a baby years ago when I was at work. And I worked in an ICU that took kids and adults both, and adults more so than babies. So everybody got a little, more nervous when we had infants up there. It's a smaller hospital with an ICU that took several different kinds of patients. So I had a baby that was post-op. Basically, doctor said, go ahead and extubate, but he was concerned that the baby would not be ready yet. So it's kind of a sink or swim kind of mentality, maybe. The nurse was given Narcan to get all the narcotics and influence of narcotics off board of the baby, or at least, speed that process up so they'd wake up more. He's just worried about would the baby maintain their own airway well enough on their own after we extubated. So he was going to stay in the room. He wanted reintubation equipment there. Again, this was over a decade ago, so maybe things have changed a little bit. This was kind of an old school pediatrician on the case, but I'll never forget, I'm so nervous and making sure all my reintubation stuff there. So we extubated the baby. Of course, the baby had a little bit of stridor, was not as awake as we thought they would be. So, I'm thinking zebra before horse, and I'm getting my reintubation equipment ready and checking my ambu bags and making sure I got the pressure manometers all ready. And he looked at me and he literally said, Chuck, let's think horse before zebra. I don't like the way that baby's positioned. Let's get a towel roll under the shoulders, get him more in that neutral sniffing position and see if that helps. And I'll never forget what a huge difference that made. As soon as we put that baby in that position, the upper airway noise, stridor, ronchi noises went away. SATs immediately rose up to like 98 and above %. So it's just, thinking simple first. Get the baby, in this case, as a baby, an infant, in the proper position. But with adults, you might need to do something a little more advanced. So more of a pronounced head tilt chin lift is what you usually need to do with adults to open up their airway. So maybe you find someone responsive, you just do that, and now the snoring stops. Maybe they have enough muscle tone that once you get their airway open decently enough, they can maintain it on their own. If you suspect cervical neck fractures or trauma, you obviously don't want to do a big head tilt chin lift on them. You're going to have to do it more of a jaw thrust maneuver. And this is all just basic review of BLS kind of stuff, but I think it's worth mentioning that you don't forget these basic things. If they would start to happen to vomit or retch like they're going to, good idea to roll them on their side, have suction equipment, namely a yank R to suction out their oral cavity. Log roll them, so again, if there's any trauma to the head or neck, you don't want to twist their head or anything like that. So have someone help you kind of log roll them quickly, so you can use gravity to hopefully prevent some aspiration, but have suction available so you can get out as much as you can if they would happen to try to suck in and try to aspirate some of it. And even though American Heart Association, BLS, does not emphasize the look, listen, and feel and it's not ABCs anymore, it's CAB. I still think that is the role of the therapist. So if it's not you, if someone else is checking the carotid pulse, calling for a code blue, yelling for help, assessing responsiveness and all that, I don't think there's anything wrong with you as a therapist going in there and doing a head tilt chin lift on them. And within 5 seconds, you should be able to look, listen, and feel for breathing. So you're looking for chest rise, listening with your ear at the nose and mouth for signs of ventilation. Same way, once you do a jaw thrust, if you suspect maybe they broke their neck or something like that, don't do a head tilt chin lift. But once you do the jaw thrust, maybe they can breathe now, maybe they can't. So getting back to the types of pharyngeal or simple airways, let's start with the oral pharyngeal airways first. Some people, it's kind of an older term, call these bite blocks, because once you put these in, patients really cannot bite down. So if you have someone orally intubated and you don't have like a commercially available bite block that fits on the endotracheal tube itself, in a pinch you can put an oral pharyngeal airway in, and think about it. When they bite down, they're going to be biting down on the hard plastic of the oral pharyngeal airway before they would bite hard enough to reach the tube. So some people call these bite blocks, but oral pharyngeal airway is more descriptive of what they are. There's two main types, and you guys have probably talked about this, Berman and Goodell. Now, in my life, in my illustrious career, I've never had a doctor yell at me and say, quick, I need a stat Berman oral airway or a stat Goodell. They just say, hey, pop an oral airway in, let's get the tongue out of the way, let's see if we can ventilate them better before we intubate them, to get the tongue out of the way. Now, having said that, so don't email or call me, or, well, I guess I won't give you my contact information, so you can't do that anyway. But if you would happen to have a doctor that gets picky, you do need to know the difference between the two. Again, in my career, it's more of a teaching thing. So a Berman oral airway is designed with the channels the air can be ventilated through along the side of, the whole length of the tube. The Goodell oral airway has one central channel in the middle of the device, so a hole in the middle. So again, I have suction with a 14 French or a 12 French suction catheter right through the hole in the Goodell oral airway, because it does put you right down there beyond the tongue, deep in the oral pharynx, getting down to right above the vocal cords, almost in the larynx, if you want to push it down deep enough. So you can get some secretions out like that, and that's kind of maybe an off-label use of it, but it is possible to do that. So the main purpose of either type of oral airway is it really is just meant to get down and get the tongue up off the posterior pharyngeal wall to relieve that as a cause of airway obstruction. Now, the big caveat or warning for this is only use these in unconscious patients, because if your patient has any kind of gag reflex at all, once you put these oral airways in, they will immediately start to gag, retch, possibly vomit if they have a stomach full of contents right away. And if that happens, you're just going to have to simply pull the airway out as quick as possible. Again, log roll them, suction them, make sure you're trying to get as much as you can to prevent aspiration. As far as proper sizing and insertion techniques, there's basically three main techniques that you can use to insert these, and really one way to size it. You just take these and put these along the side of the patient's face. Again, they're unconscious or out of it. They're not going to even know what you're doing. You should always tell the patient what you're doing in case they are hearing something that you're saying. I guess we never know how much they can hear, but you can explain what's going on to them just as a matter of good practice. But lay it along the side of the patient's face, and you want it to reach from the opening of their mouth, and then the tip should reach down to the angle of their jaw, which if you followed upwards should be about even with the tragus of their ear. That's the little sticky out thingy, I don't know how else to call it, of the ear. It's not the earlobe, it's a little part that's a little higher up that sticks out kind of 90-degree angle from your head. And this, it's more art than science. I mean, you can do it that way. Some people say, yeah, you go from the teeth to the angle of the jaw, or you got to make sure the flange of the airway, which makes sense, the flange should be outside of the mouth, just right there, so they can't suck this whole thing down in the airway and obstruct it even worse. So again, the Berman and Goodell, know the differences between those two. It's more of a teaching point. Bermans are a little I mean, they're harder along the whole length. Some people like Goodell Airways because where a patient might bite into, it's actually a little bit softer plastic than the rest of the body is. So less of a chance that they might bite so hard, knock their own teeth out. Never seen it happen, but I suppose it's possible. So that's as far as the sizing, that's it. And it really, usually in kind of a hurry when you put this in. So again, I think it's more art than science. You don't have to spend 10 minutes trying to size these and get them exactly perfect. Some hospitals you work at might have limited options. Maybe they only carry one style of Berman or a Goodell, and maybe they only have two or maybe only just three sizes to choose from. I've seen a lot of places, and it's usually for cost saving. Okay, you're an adult, here's 2 adult-sized Airways. And they might be sized by millimeter in length, so like 70, 80, 90 millimeters in length. Or others, I've seen different brands just have a number and print it on the flange. So a 3, size 3 is smaller in length than a size 5. I don't think those numbers mean much to me. I don't think, the bottom line is you still got to size it the way I just talked about. As quick as you can, try to find one that fits as close as that description as you can. And then you don't need to use any kind of water soluble lubricant or anything like that. As far as techniques to pop it in, if you have a tongue depressor, or some people call them tongue blades, available, you can reach in and without doing any twisting or anything fancy, just lift the tongue up off the pharyngeal wall and pop the oropharyngeal airway in without twisting or to do anything fancy. And when it's in place, it should rest so the flange is kind of outside their teeth so they can't aspirate or suck the airway down any deeper. And you're done. Most people don't have tongue blades readily available, or tongue depressors, whatever you want to call them. And you don't want to delay things by saying, quick, I need a stat tongue depressor. People are going to look at you weird. So you can twist them. You can come from the side of the mouth and you put it in sideways and then twist it 90 degrees so it's anatomically reaching down and scooping up the tongue when it's in its final resting position. Or you can do what I call, it's the full twist, a 180-degree twist. So you pop it into the patient's mouth upside down, and about halfway down, because of the way it's rubbing against a hard palate, you'll feel like a change in resistance. That's when you twist it and advance it the rest of the way. So you twist it a full 180 degrees. So again, you insert it completely upside down. When you're about halfway down, you do a full twist, and so it should be resting in the proper anatomical position. These things look like basically, I guess, kind of crude C-shaped devices. So you want the tongue to be kind of scooped up within that C shape. So that's how it needs to be resting when you got it in proper position. Which makes sense. I just had a student last week, we were playing around with these in lab, and she put it in upside down. She started that way, but when she got done putting it in, she didn't do the twist. And she knew right away. She's like, this is feeling really weird to put in. And she got done and said, okay, is that right? And I said, no, think about it. Is that going to get the tongue out of the way or probably make things worse? And she said, oh yeah, it's not going to help because the C-shaped little groove there didn't lift the tongue up. You just probably made things worse and probably traumatized their hard palate by scraping it the way you did. So again, it's okay to do that on mannequins. I'm sure she'll never forget that, and she'll know, okay, I need to do the twist, either a full 180 or a 90-degree turn if you come in from the side of the mouth rather than directly into it. And there's all shapes and sizes. They make oral airways from that can fit, newborns all the way up to old geezers. Again, I don't pay as much attention to the millimeter markings as length or the numbers if that's what the brand comes in, because to me the bottom line is you still have to at least quickly size them the way I described. Whether it's Berman or Goodell, you at least got to go through the steps of getting that. And again, it's more art than science. Now, if you put too small of one in, maybe your patient can actually aspirate it partially, or it can obstruct their airway if they open their mouth wider and they suck that down. That'd be terrible. But the big thing is, if it's too small and you don't size it properly, it's not going to do what it's supposed to do. Namely, it won't get the tongue out of the way. It needs to be long enough to go down and actually reach behind the tongue and lift it up off your pharyngeal wall. Bad things that can happen if it's too big, as you can do more damage to the mucosa and palate as you're putting it in there and scraping tissues. And if it's too big, you can actually obstruct the epiglottis from moving the way it should. So that's definitely longer than what it should. It's just meant to go down and get behind the tongue. It's not meant to reach clear up to your larynx and, start messing around and touching your epiglottis. So if they do have a gag reflex at all, if you got a properly sized one, maybe they are not that bad. But if you got one that's way too big, you're definitely going to make them gag and vomit and have problems and cause a bunch of distress if you're tickling their epiglottis. Or, that's another risk, possibly damaging it. The other type of pharyngeal airway or simple airway are nasal trumpets or NP tubes, nasal pharyngeal tubes, whatever you want to call them. These are made mostly out of soft rubber or silicone or polyvinyl chloride most commonly. Again, the main purpose is they do reach down and get the tongue up off the back of the pharyngeal wall. Maybe not quite as good at doing that as the hard plastic oral airways, just because they're rubber and maybe they're not stiff enough to do that as effectively, but they do a decent job in a pinch. What the most common reason why you'd maybe put a nasal trumpet in is you have a patient that you predict is going to need frequent nasal tracheal suctioning. So to save them trauma to the nose and turbinates and upper airway from you jamming hard plastic suction catheters down their nose every couple hours, put a nasal trumpet in and life is good. As far as things to worry about with these, you should always lube these up with water-soluble lube. Never use petroleum-based lubricants because your body does not absorb that stuff, so all that lube would stay all gunked up and it can be toxic to some patients. Their mucosa doesn't like that, so they might have a reaction. But water-soluble lube is usually well tolerated by everybody because it's water-soluble. I never heard of a patient being allergic to water. That would not be good if they were. Wouldn't have a very good life. So some things to worry about or keep in mind. If they have obvious facial or nasal trauma, you should not be poking things up their nose because you might actually rupture sinuses and end up maybe getting up to the cranial cavity, namely poking the brain. I guess that would be terrible. And so something you need to worry about. You have obvious bone fractures, maybe things are not going to go the way you want. If they've had a broken nose or deviated septum, you might not be able to push the nasal trumpet down one nair, and the simple thing to do is just pull it out and lube it up again and try the other nair. You want to push firmly, but not so hard that you're popping things through and causing false passages and massive trauma. If they have uncontrolled, bleeding problems and their blood's not coagulating properly, probably not a great idea to be poking nasal trumpets into them. I've seen patients bleed pretty bad from those, even ones that are sized properly and placed properly. Some hazards. And I've had this happen to me, this has been years ago, but if you put nasal trumpets in and kind of leave them in for way longer than what you should, they can actually adhere to the tissue, so they can literally get stuck. And this happened to me maybe twice in my career when I went to take one out of a patient, and it's like, okay, I didn't expect this. I didn't expect it to be hard to pull out. The only thing I figured out to do is to just try to get some water-soluble lube and lube it up as much as you can access and kind of work it up and down until the lube is spreading into their nose and getting more of the tube coated. Then it comes out. But just be aware that you might have a pretty significant nosebleed. So the way to fix that, and a lot of hospitals do this, they have policies that say if you're going to put a nasal trumpet into somebody, maybe you need to take it out and give the patient a break every 4 hours, or every 4 hours, if you still think they need it, take it out and put it in the other nair. So you're relubing it, cleaning, disinfecting it, and things like that to prevent a tissue adhesion to it. So, once you put these in, like me, I was found patients that had them in for 2 or 3 days and no one had done anything about it, because we really didn't have a policy in writing that said what we should do. Now, after it happened, everybody flipped out, and then we had more things in writing saying, okay, this is what you do. So that's one reason why some docs maybe don't like that. They don't trust us, or if you do get the permission and put one in, they'll say, hey, at the end of the day, you got to take it out because we don't want to keep those in for more than a shift or more than a day, whatever. Anytime you put anything into someone's nose, whether it's an endotracheal tube, nasal trumpet, NG tube, there's a huge chance that the patient's going to get sinusitis just because you're blocking normal drainage from their sinuses. So again, that's a risk you take when you put these nasal trumpets in. These are big honking things that really do obstruct sinus drainage in that narrow. So they can cause some sinusitis. In the grand scheme of things, maybe that's low on the totem pole, but you know, if we're in the business, we don't like to cause infections. And when you put something in knowing that there's a high chance of your patient getting one, that's when doctors maybe get a little iffy on whether the ends justify the means and whether it's worth it. And again, if you're maybe not using enough lube or you're forcing things and getting a little too rough when you put these in, you can do some damage to their nasal mucosa, maybe lacerate the turbinates in their nose, and that's bad because that's the part of your nose that heats and humidifies everything as far as when you breathe in through your nose and the air. So that can last, affect them the rest of their life. As far as insertion technique, like I said, just lube it up with water-soluble lube. Personally, I like to put my patients up in more of a semi-Fowler's position, maybe do a little bit of a head tilt, chin lift, or a sniffing position to kind of get their nose up in the air a little bit more. Then once you got it lubed up, maybe about the bottom, distal third of the tube, you kind of go upwards and you follow the normal entrance to the nares. But as soon as I got it, what I think is reaching the turbinates, you'll meet a little bit of resistance. That's when I change my aim and really push it and aim down and towards the septum as I twist it to get it through those turbinates. I've never seen that not work. I've seen some patients where you don't have to do much twisting, but in my experience, you follow the normal curvature, so you're kind of aiming upwards as you follow the floor of the nose. But when you start hitting turbinates, if you don't change your angle, you're just going to be more likely that you're going to ram this up into the sinuses or someplace it doesn't need to go. So kind of follow the natural curve upwards. When you start to meet a little resistance, that's usually the turbinates. That's when I change my aim and really kind of, not violently, but really make a big change in my directional push and aim down. So I kind of get up on top of it and push down towards their feet and aim it towards the middle as I twist. And you got it lubed up so it should pop through there. Again, if I meet too much resistance, I don't want to hurt the patient. Maybe the patient had a broken nose or deviated septum that's not documented, and then just try the other nair. So that's really, I guess my other clue or tip for you is once you decide to put these airways in, do it. Don't be a wimp. I've showed my patients some videos I found online and YouTube and things of students, EMT students, respiratory students putting nasal trumpets in, volunteers, including their instructor. And I always tell my students, don't get excited because I'm never going to volunteer for that. But the biggest problem I see is they take way too long to do it. And it's understandable because they're nervous. They're afraid they're going to hurt the patient, especially since they're awake and alert. And definitely when it's an instructor, you don't want to give your instructor a bloody nose. Maybe they'll give you an F for the semester or something in revenge. Hopefully not, but you never know. And so that's what I tell my students. Once you decide to do it, do it. Use the proper technique. Don't be a wimp. Use firm pressure, but not, pushing as hard as you can or anything to pop these things in. And it should be popped in within a few seconds. It shouldn't be a really hard airway to place. And again, in my opinion, if you take too long and you're trying to be too gentle, you're making a lot worse on the patient, especially if they're awake and alert and have a very active gag reflex. They feel everything you're going to do. One video showed the volunteer just said, go ahead, push it, do it. Quit messing around and get it in there. So some of these airways, I've worked at hospitals and sent students to hospitals where nasal trumpets are used a lot. Others, I just talked to one and said, I don't think we have these stocked anymore at all in our hospital, which was kind of shocking to me. But they said, yeah, we haven't seen those in years, because I just put a call out to my clinical sites when I realized we were getting low on nasal trumpets in lab and just said, hey, do you guys got any expired ones or any ones you could spare? I really want the students to get more hands-on experience with them, and the ones I have all the French sizes eroded off because they've been out of the package for years and used so much. I just wanted a new one so the patients could see how they're sized and what the package looks like. And again, the one hospital said, we don't even have those, and that's kind of shocking. So it depends on where you work. Also depends on how aggressive you want to be. If you are a therapist that is not aggressive with nasal tracheal suctioning, maybe your hospital kind of frowns on that. you might not even have these. On the other hand, if you're really into this and you want to be aggressive and really help your patient and get some good pulmonary toilet done, you don't have to use nasal trumpets when you nasally suction patients. You definitely need to if you think they're going to need frequent suctioning. It's the best airway to place if they're awake and alert at all and have a, you don't have to intubate or trach someone just because you think they need suction. But even if you think you're just going to suction them once or twice, if you're worried about causing trauma, it's probably a good idea to pop a nasal trumpet in first, just to protect their mucosa and give you a more direct, easier route to get the tube down where you hope to get it into the trachea. It's still not a 100% guaranteed. If they still have an active gag reflex, they can divert it, and maybe their epiglottis is kind of flopping around down there and shutting their airway, and when they feel the tube coming down too. But you do the best you can. So hopefully you found this lecture worthwhile. The next little module I want to record, we'll get into the more advanced airways, and then we'll end up lastly with the tracheal airway. So thanks for listening, and have a great day. See ya.